Good evening, ladies and gentlemen. Welcome to our first town hall event regarding the topic of suicide. My name is Richard DeFord, and I'm the Marketing and Public Relations Coordinator at Fitzgibbon Hospital, and also a chaplain at Fitzgibbon Mary Montgomery Hospice. And I'm also the pastor, or associate pastor, of Katy Park Baptist Church in Sedalia. This meeting tonight would not be possible if it weren't for the team of people that worked to put it on. So what I would like to do is have those individuals who worked on this evening stand up so that we can recognize you for all of your hard work. There's several of you present. Yay! And there's also several that said that they were not able to be here tonight, and so we are videotaping this meeting tonight so that we can make that available for them as well. If you are a member of the Mental Health Association of Saline County, would you please stand? Yes, thank you very much. This is a Mental Health Association of Saline County event, and we are very thankful for their work as we address the mental health needs of our community. First, some housekeeping items. If you haven't been here to Covenant Presbyterian Church before, the bathrooms are just down the hall here to the right outside the door. So you'll want to avail yourself of those when you need. Don't worry about the camera. The door is right there, and you can just go on through and don't worry about it. Some people may, well, I don't want to be on camera, but that's okay. On the panelist flyer that you have in your bag, that is kind of a program tonight where you will see each of the biographies of each of our panelists tonight. We are going to introduce them later, but the full bio is contained there on that guide. I would like for you to make sure that you recognize all of the organizations that help put this on tonight. We have several sponsors, including the Mental Health Association of Saline County, Burrell Behavioral Health, Covenant Presbyterian Church, Fitzgibbon Hospital, Fitzgibbon Mental Health, Great Circle, Marshall Ministerial Alliance, Marshall Police Department, and Marshall Public Schools. And lastly, I want to thank Powerhouse Ministries very much for their donation of all of the food that we have tonight. We talked to them about providing cookies, and they went all out and provided a full spread. So that was definitely a blessing. Thank you to them. This meeting is a chance for us to hear from some local experts about the warning signs of suicide. We'll hear local and national statistics, the effects of suicide on loved ones, and the resources available in our own community. We truly seek to be a community that is united in our stance to end suicide and support those who are struggling with the mental, emotional, and spiritual storms that often lead to suicide. So let me tell you what this meeting is. It's a chance to ask questions of the panelists. Each panelist has agreed to be as brief as possible in their responses, while also working to correctly answer the questions. Their brevity will give us the maximum time to answer as many questions as possible, and we want your questions. That's what this is about. Nobody came in here with a full presentation to do for you tonight. This is a chance for you to ask your questions. To submit your question, you'll provide it in writing to the Mental Health Association of Saline County President Jackie Carton. She's back there at the table, and she's got a box. Or also several of the Saline County the Mental Health Association of Saline County folks that stood up a little bit ago. They're going to circulate around some of those papers in a little bit, and they'll collect those from you as well. Also, the members of the Saline County Mental Health Association, they certainly, I'm sure, would like for you to entertain membership in their association. I'm sure you can also talk to Jackie about that later as well. She's going to sort out the questions and prioritize them to make sure that we stay on point, and also she will provide those to me, and then I will ask them of the panelists. Now, a word of what this meeting is not. This is not a political meeting of any kind. We all know that there are certain political ramifications for numerous issues, including funding, Affordable Care Act, physician-assisted suicide, and others. This meeting is not designed for political debate. We saw enough of that the other night on television. We want to make sure we stay on topic and avoid these political topics so that we can all learn as much as we can about how we can affect suicide right here in Saline County. I'd like to introduce our panelists tonight. There's a more detailed biography, as I said, in your packet. But first, we will introduce Mary Farhmeier, MD. She is the psychiatrist for Fitzgibbon Mental Health and is also the psychiatrist for the Behavioral Health Unit at Fitzgibbon Hospital, the only inpatient option for someone in a mental health crisis within 60 miles. So, Dr. Mary Farhmeier on the end. Keith Bishop has worked for Butterfield Youth Services, now Great Circle, for over 30 years. He is the Director of Home and Community-Based Services, and in this role, he often works with children who come from traumatic situations. Keith. The Reverend Dr. Dan Festa is the pastor here at Covenant Presbyterian Church. In addition to be a pastor, Dr. Festa has worked as a chaplain in numerous healthcare settings and has also counseled with many families in the aftermath of a loved one's passing. He is also an author of the book entitled Through the Eyes of the Heart, Stories of Love and Loss, which is available tonight after the presentation as well. Dr. Festa. Lindsey Parton is the social worker for the Marshall Public School District and graduated with her master's in social work from the University of Missouri in 2011. She's continuing work towards becoming a licensed clinical social worker. Lindsey. Roger Gibson is a law enforcement officer for the Marshall Police Department and serves as the police department's public information officer. He also serves in this capacity for the Saline County Emergency Management Agency. Roger. Last but not least is Marla Stretz. Mrs. Stretz is a retired school teacher from the Pilot Grove School District. Her son, Clark Cody Stretz, died by suicide in 2009, and since she has been an advocate for suicide prevention and mental health education in public schools. In addition to her biography on the flyer that you have in your bag, she also has a story that lets you see a picture of Cody and her family and kind of lets you know a little bit about what she has been through to get to this point tonight. So, Marla Stretz. These are your panelists, and at this time I'm going to bring up Keith Bishop, who is going to provide us some context for information about suicide. And following that presentation, we'll begin asking the panelists your questions. At any time, you can give your questions to Jackie Carton back at the back. Keith?
First, thank you everybody for coming tonight. I think this is a good start to a serious topic, and our hope is that by everybody attending tonight that we will increase our awareness of suicide prevention, and start the process of open discussions. Suicide is something that we do not talk about much. I think most people would rather talk about almost any topic on the planet besides suicide. I think there's lots of reasons for that. Maybe part of the reason is you're afraid of the answer that you'll get if you ask somebody a question. It's kind of, don't ask if you don't want to know. But I think we have to get past that. We as a panel believe that talking about suicide, increasing our awareness of the topic, is the key point of suicide prevention. That if we're not talking about it, we can't stop it. Tonight's town hall meeting is not intended to provide a comprehensive understanding of the topic. It's much too complex for that. Suicide is a very complex process. It can be very different for every individual, so that is not our goal. It's not intended to make us all trained professionals of how to deal with a person that we come up against who may be suffering and contemplating suicide. We do hope to provide information that will help you know what to do if you are worried about someone, and provide you with confidence to act on that person's behalf. We also hope tonight to increase the general awareness of this issue and encourage individuals to talk openly about this serious topic. And so the high-tech part, I'm going to have to walk back here real quick and push a button. So the first question we ask is what is suicide? And basically suicide is self-inflicted death. The part that gives us hope as far as working with this population is that most people do not want to die. What most people really want is for something to be different, but it is a permanent solution to a temporary problem. And so most problems will change or improve if given time. A solution can be found to a problem if given time, or a person can develop acceptance to a problem that maybe the problem cannot change, but a person can develop acceptance to it and ways to cope with it if given time. So our best preventative tool when it comes to a suicidal person is to buy time somehow, however we have to do that. If we can get the person past that brief window, usually brief, then we have a pretty good chance of getting them on to not think about suicide, think about solutions in other ways. Some brief statistics. The first one, suicide is an equal opportunity killer. It doesn't matter what race you are, it doesn't matter what religion you are, age, gender, suicide affects every population that we have. It does have a higher incidence for middle-aged Caucasian males. If we were going to talk about one group that's more susceptible than any other group, that would be it. But it's the 10th leading cause of death. Almost 43,000 Americans die every year from suicide. That comes down to 117 per day, which is a shocking number, shocking to me. It's estimated that for every successful suicide, there's 5 attempts. Females attempt suicide 3 times more often than males, but males are successful at it 3.5 times more than females. A way to think about this that really strikes home to me the numbers is I watch the news about once or twice a week. That's about all I can usually deal with it. But every time I watch the news, and Kansas City is the channel I watch, every time I watch it, I see 1 or 2 murders every time. And the statistic that put it into perspective is for every murder that we have in the United States, we have 2 suicides. We never hear about them, but they're out there. Unless they're a celebrity or maybe we might hear about them in smaller towns a little bit more than the bigger cities. But we hear about murder all the time. Suicide is a bigger issue as far as our national population. I throw this statistic in here because it explains why men are more successful than women. 50% of all successful suicide attempts are by firearms, and firearms is the method of choice for males. And this is something that I think is useful to know if you're dealing with somebody that you're worried about. One of the risk factors that we would take into consideration is, does this person have access to a way to commit suicide? And firearms in the home is a one that we would worry about a great deal. Okay. Some terminology, just so we can talk the language a little bit. We have suicidal ideation, gestures, attempts, and then the completed suicide. The ideation is a person is thinking about it. They're not talking about it, they're not telling anybody about it, but the thought is there. If it moves to the next step is a gesture. And the gesture could be they start making statements that make us think that they're going to kill themselves. They may start stocking up on a way to carry out the plan. They may do other things. Sometimes women or teenage girls especially will cut on themselves in a superficial way, start engaging in risky behaviors. All of these would be what we would call a gesture. The attempt moves more to where they actually engage in a behavior that would be lethal, but for whatever reasons it gets stopped. And then of course the completed suicide is self-explanatory. And the reason I bring this up is the suicidal ideation is a very critical moment in a person's journey to deciding that they are going to carry out a suicide. And it's the thoughts, and it all starts with the thoughts. And so I think this tells us why it is so important that we ask. Because one of the routine things that we do in my work, and psychiatry does it as well, is when we see clients, one of the first things we'll ask them, or something we ask them before they leave, is, are you thinking about hurting yourself, or are you thinking about killing yourself? And an amazing number of the clients will tell you, yes I am, or yes I have. And so I think that if we're worried about a person, the fact that it starts with a thought tells me that we need to talk about it. We need to ask them. If you're worried about a person, just ask. It also says why it's the importance to raise awareness. It's the importance to increase discussion. It's the importance for us to feel more comfortable with this topic, and hopefully not be afraid to ask, not be afraid of the answer that you might get, because that answer is what allows us to do something to stop it. Next. The next slide is talks about the signs and the talk and behavior and the mood. And for it, I'm not going to go into them in great detail here right now, but I do want to point out that we have a brochure in everybody's packet, and we have extras if anybody wanted to take some and distribute them around. But it talks about on the back page, it talks about the type of talk that you might hear, or the type of behavior that you might see, or the moods that you might adjust, or you might witness. And I'm not going to go into them one by one, but I do encourage everybody to look at it and read it, become familiar with it. And then the next slide is what can I do, and it's very simple what we can do. We can listen, and we can ask, and we can call. And I think, if we're worried about a person, if we hear things they're saying, or we see things that they're doing that make us just wonder, are they doing okay? Ask. If they give us or listen, and then if they give us if we start seeing signs or hearing things that worry us, ask. And if they give us an answer that lets us know that yes, I am thinking about suicide, yes, I am not doing well, then call. And call for here probably means call 911. If you can talk them into going into the emergency room at Fitzgibbon, that'd be great. But if you can't, you don't leave the person. They don't tell you that yes, I'm thinking about committing suicide, and then you say, well, I wish you'd go to the hospital with me. And they say, no, I don't want to. And you say, well, maybe I'll talk to you tomorrow and see if maybe you will. Once a person has made a statement of this nature to you, I don't think you can let it go. I think you have to push it to the point of getting them the help. And if that means calling 911 and having the police come out and do an assessment, or having the police take them to the hospital for an assessment, then that is the thing to do. And the person may be mad at you. They may not talk to you for 2 weeks or 3 weeks, but most of the time they will eventually see that you did it because you were worried about it. You did it because you were concerned about them. And it beats the other choice. And that you say, well, okay, and then something terrible happens, and then you have to find a way to deal with that. And so we'd just like not to have two victims in that process. That's my basic presentation. I think, I hope you have questions, and thank you.
Thank you, Keith. All right, at this time, several members of the Mental Health Association of Saline County are going to pass out some question pages to make sure you have an opportunity to ask your questions tonight. I do have a couple questions for our panelists, just to give you an opportunity to write those questions out and get them to Jackie Carton. First question is for Dr. Mary Farhmeier. Dr. Farhmeier, if a person has a very real fear that someone they know poses an immediate danger to themselves or to others, what can they do to make sure that person gets help?
Like Keith said, one is to try to talk them into going to the emergency room so they can be evaluated. The other is call the police. We have trained, at least one trained CIT officer on the Marshall Police Department, and we also have some trained CIT officer on the Sheriff's Department in the area in Saline County. What CIT is Crisis Intervention Team, and they're trained on mental health and how to assess and decide whether they need to bring someone in, and oftentimes they will bring them into the emergency room themselves. The other is what's important about that is for you guys, if someone says this to you, to come to the emergency room with them, fill out information for us, because we have family members that will drop someone off and they disappear, and they won't write anything down for us. We have what we call affidavits, and those are so important for us to be able to get someone help, that whenever they hit the emergency room, they shut down, or they won't talk to us, and they won't give us the information that they just divulged to you. And it's got to be, if you tell me, that's hearsay. But otherwise, Missouri does have, if they're imminent harm to self or others, we can put them on a 96-hour hold and admit them to the hospital to get them treatment.
Okay. Also, while you're there, there was a national news story that broke recently about a young mother who died by suicide while dealing with postpartum depression. Can you talk a little bit about postpartum depression and what folks can look for with someone who is struggling with it?
So postpartum depression, about 30% of moms will suffer from postpartum depression. About 80% of moms will have baby blues. The difference mainly is in postpartum depression, the baby doesn't want to attach to mom. Mom doesn't really address the baby. They tend to want to isolate. They're sleeping all the time or they can't sleep at all. They feel isolated. Some things that we can do to kind of help that out is to make sure that new moms aren't isolated and they have the resources. There is very differing information regarding the rates of suicide with postpartum depression. It can range up to 25% of those suffering from postpartum depression. I can tell you from my experience in dealing with the postpartum depression, it can be some of the hardest to treat depression out there because there's so much stress and lack of sleep with the newborn babies. And generally, if they do become psychotic or have psychotic type symptoms where they're not connected with reality, it usually occurs within the first 2 weeks and can be, there are quicker and easier ways that we can deal with it, and besides just medication also.
Very good, thank you. Keith Bishop, I've got a question for you, sir. Your focus at Great Circle obviously is children in crisis and that have been removed from homes, and some of them have experienced traumas. Talk about some of those traumas that can lead to suicide for youth. What is the effect of the things that are going on in their homes and how they come to you?
Okay. There's a lot of research that supports the fact that chronic trauma or extended trauma or repeated trauma has a extremely negative impact on development and negative impact on social development and brain development. And so a lot of the people who are exposed to the trauma for long periods of time, there's correlations with social issues, there's correlations with alcohol use, there's correlations with lots of physical health problems, and so there's a reduction in ability to control impulses, stress, people become overreactive to stress, and all of these combine in a way to where if a person is placed with a circumstance that may not seem like a big deal, given their history and given their makeup at that moment, they are not as capable of dealing with the stresses of day-to-day life. You throw in alcohol with it, or any drugs really that reduce inhibitions, and many of the people that I work with have what we call kind of an impulsive suicide attempt. They don't really think it through very well. Something hits them without giving it much thought at all, so there's no warning signs for very many people. They are doing something, again, maybe did not truly want to die, but the impulsive behavior is such to where they do something that will kill them. And this continues on into adult life, that people who have childhood traumas carry this on throughout, and so they're at risk for very long periods of time in their history.
Okay. While you're there, Keith, I have a question from the audience. Do agreements work where if thinking about suicide, you have them sign that they won't take action without calling you or someone else? Do those agreements work?
I use them. I think I don't recommend that as a strategy for people out in the community, but it is a strategy that I do use in my therapy with people. And for the most part, yeah, but usually I have lots of other things that I'm looking at also. I have a pretty good idea what their support systems are. I have a pretty good idea about what their ability to carry off or carry out the suicide is. I would know there's no guns in the home would be an example. And so, yes, my answer is yes, but I recommend it to be held to trained people to engage in that.
Okay. Thank you, sir. Dr. Festa, we have a question for you. From the audience, some people have been taught that suicide is an unpardonable sin. Do you agree or disagree?
What I can say is the God that I know and believe is a God of love and a God of mercy and grace. And the God that I know and believe is not somebody who would ever view anything like the completion of any kind of death, whether it be suicide or any other kind of death, would not be an unpardonable thing in the God that I know and believe.
Okay. Very good. While you're there, I've got some other questions for you, or another. As someone who's served for many years as a chaplain and a pastor, can you explain the effect suicide has on family members and friends, both in the immediate and the long term?
Wow. Do we have a week? I think that there are so many factors that come into play when somebody dies by suicide. Certainly, you've got to look at the nature of the relationship. Was there with family? Were family close? Were they distanced? How was it done? Was it done? And why I say that was sometimes I've been a part of suicides that were meant to be wounding. I worked with a neurosurgeon for many years, and his eldest son killed himself by shooting himself in the head. And that was intentionally directed at his dad. I mean, they'd had a very conflicted relationship, and because his dad was a neurosurgeon, he chose to kill himself in a way that his dad could do nothing to help him. And it was very difficult for that family. And I think for families, I think the sense of isolation, and I know Marla's probably going to talk more about that, but I think that that's one thing, because there is still so much of a stigma that exists within our culture around suicide that people get isolated, whether it's intentional or unintentional. It happens because most of us are uncomfortable with how to deal with it, how to talk to somebody who's had a death of a loved one by suicide. And and while I see a lot of ribbons here tonight, I know that many of us here have been impacted in one way or another by the death of a loved one. And that's great, but in the general public, people don't walk around wearing their signs saying that they've been impacted by suicide. And so the isolation that can happen because people are afraid to mention it, afraid to talk to them, afraid to ask them questions, afraid to say anything. And Marla and I were really having an interesting conversation before this began. And the parallelism in some of what we both experienced was amazing. And I think that happened because we started talking, and weren't afraid to talk about it. But I think so many people wind up isolated and insulated from it because of the fear of what to say. And I think that the ongoing impacts for families, many families do not manage to stay together if it was the child that killed themselves. Many families dissolve through divorce because of their inability to deal with it. And that can be with a childhood death anyway, but certainly that's amplified by suicide. And I think that certainly the questions that come up are all of the what ifs and the if onlys. If only we'd done this, if only we'd known this, if only we'd seen this or understood this. And the, if we'd done this, or we woulda, shoulda, coulda, and so I think families live with that for a long time. And I think, even many congregations are not prepared, and I don't mean that people don't want to be helpful, but again, that fear of intruding in somebody's private life or being involved with them as somebody who's suffered the death. I mean, a heinous death. And I think folks can wind up feeling very isolated. And I'll stop there for the moment. I could say more, but sure.
Yeah, go ahead. Nobody knows when to clap, when to not. Just clap. Just have a good time with it. At this time, we're going to put Roger Gibson in the hot seat.
Okay.
If 911 is called for someone who is troubled and maybe considering suicide, can you walk us through what the law enforcement process is?
Well, first of all, our dispatchers are our first line of defense. They're very well trained, not only at MPD, but Saline County 911, where that call is going to go more than likely. They have a protocol in place, step by step. They're going to ask you a lot of questions. Just be patient. What you don't know is that they've already dispatched us. Emergency personnel are on their way. While we're going, they're trying to obtain information from you. Medications, things that are going on in the household, firearms, are there anything that we need to be aware of as we approach? Upon arrival, I know a lot of them get intimidated by us, but thanks to some training, Miss Anna White, thank you. A lot of the officers are trained how to deal with it in the academy and continuing education as we go on to deal with these things. So, can it be scary? Yeah. Do we ask for your help? Yes. Any information you may think, why are they asking you this stuff? It's something that we need to know to help us, to help them. And so after that, and once upon our arrival, we make that connection with that individual, we just start our process of what we've been taught. And eventually they start to feel more comfortable. We build a rapport. And a lot of them do not want to go with the ambulance. They'd rather go with us. And so we don't mind that. I mean, we're not going to throw them on the ground and handcuff them and drag them through the mud and put them in the car and make them go. No. Before it's all said and done, we've been able to use our experience through all these years to help them say, hey, we understand where you're at and there's help out there. So then we go through all that protocol and we get them to the emergency room. And usually they're monitoring our radio frequency, so they've already picked up on what we're dealing with, kind of what's going on. The information that the dispatcher is passing on to us, they're able to obtain. So if they're on medication, what they're doing, if they're under counseling, things like that. So there's a lot moving and grooving with everybody, because if they know that particular physician or counselor or whatever, they're already contacting and trying to get even more information so that when we get there, it's an easier transition for them. So,
thank you very much for that. While you're there, I've got another one for you. What would you say to those who may say that they do not want to call 911 when someone is in danger because law enforcement may make the situation more difficult or worse?
wow, that's a good question. I mean, I totally understand that they know them better than we do. They know where they're at and whatever's going on. But I would recommend, yes, please let us get involved. We have the resources. We have the people that we know that can help them. We're trained to handle that situation, whether they be armed, unarmed, whatever's going on in that household. More than likely, we can deal with that. With everything that's going on in the world, they think that we're just going to go in and shoot folks. Well, preservation of life is number one for us. It always has been. That's the way we're taught. So we're going to do everything we can to help that individual. get them over to the hospital, get them the counseling they need. And so I would highly recommend, please get us involved. Let us get there and help your loved ones, friends, or whoever they are.
Thank you very much.
That's it.
Another question from an audience member for Dr. Mary Farhmeier. What do they do when someone comes to the emergency room after stating that they're thinking of suicide or just talking? How do you get them to stay? Do they have to have a suicide plan?
They don't necessarily have to have a plan to stay. Once they come to the emergency room, they're evaluated by the emergency room staff, who often call our nurses on our BHU, our mental health nurses, or the social worker, to go to the emergency room and evaluate them to see where they stand. Is this something that we can get them an immediate appointment the next day or within the next week to kind of get them worked through and wrap around services, or is this something that we need to admit to the hospital at this moment in time to get taken care of? We often, if they're having suicidal thoughts, try to talk them into coming in. It's not always feasible. And then you do have the 96-hour hold, and that's what I was talking about earlier, is the state of Missouri, it's eminent harm to self or others. So we do have to have the information about, were they talking about a plan? Were they talking about doing something immediately, within the next few days or so, or next week? What's their plan? And some people won't divulge the whole plan, but they give you kind of hints here and there. And so the more information that you're able to provide us and how long they've been talking about it and different cues and stuff, the more likely we're able to make a good decision about that. Because it is difficult in the emergency room. We often have people show up who the family brought in and they said they were suicidal, and then of course they change their mind once they get to the emergency room, and we have to kind of dig it out of them to kind of get the information.
Okay. Thank you very much for that. I'm going to ask this question to anybody on the panel. Anybody who feels like they can address this question, just say, I'll take it. Don't all speak at once, but this person says, my educational background is in journalism, and I worked in newspapers for about, I guess it's 24 years. We never reported on suicide in obituaries or in a news story for fear it would encourage someone else to attempt suicide. Do you think it would be better to report suicides so that the community could begin to have a discussion about it, or do you think it is safer for the community to not read about suicide in the newspaper? Is there somebody that would like to take that?
I will.
Okay.
Yeah. So it's really obvious to me after this happened with Cody. I would get the Kansas City paper from my dad because he was at Katy Manor in Pilot Grove, and he hardly ever read the newspapers when he got his A's. He kind of just went through the motions, so I'd take them home and read them. But I just started this habit of going through the obituaries. And, you always knew when they died unexpectedly at home. It was always new. And then you try to see what the memorial was. And, we were very open about Cody, and we had the memorials to NAMI, National Alliance of Mental Illness, and so that was a big tip-off for anyone that read it. But I thought I was really making a stand to do that. I was really having guts to do it because most people do not. And then later on, I live in a small town, and originally from Boonville, and I would see these obituaries. We were out of town once, and of someone I knew, and it said, again, unexpectedly from the home. And, you have to ask around, it was suicide, it was, And it's really, I think it hurts people around to think that you didn't have the confidence in me that I would not judge you, that I would not give you love for that, that I would not accept you, that I would turn my back on you. You need to be open. And I've been through NAMI meetings and things and learned from professionals that actually mentioning it is not going to encourage suicide at all. And so, I think discussion's important.
Okay, thank you. While you're there, I've got a couple others for you.
Okay.
Trying to be efficient. As a parent who's experienced a child's death by suicide, what advice can you give to parents?
Okay, I had 4 points here in
Okay.
case I got nervous. Okay, I think communication is really important, and it doesn't just start when you're thinking they're this close to suicide. It starts way early. And I think people, although suicide is, can happen, we need to worry about it right at in the last minute when it's going to happen. Those thoughts, living that life, living those thoughts, starting those habits start way before. That feeling of loss, that feeling of hopelessness, that feeling of isolation could be years in the making before it comes to suicide. And I think communication is important. We're used to saying, oh yeah, communicate with your kids, communicate with their teachers. But do we ever, once they get to be about that 17 or 18, do we really communicate with maybe who they work for when things kind of seem kind of off? Do we ever communicate with their friends when they tell us, oh, they all turned against me that night, they left me? And well, gosh, we find this out later that, Cody was dealing with psychosis and he was being paranoid. These things weren't really happening. You believe your children, just like when they're 5 or 6 and they say the teacher was mean to them, you think, oh, they really must be. And so, for years, I think that we really didn't stop and call. And that's a hard thing to do, to communicate with those. It's not polite, or you're messing with their business once they get to be a certain age. So I think communication is really important. Also, we found out after Cody died that he had called all of his high school buddies that he hadn't been in touch with for years. He graduated in 2001, he died in 2009. But he had a small class of 25. He called all the boys in his class and made amends with them. Anything he'd ever done wrong for them, he didn't want everything to be good. But we didn't know. And when the girls came to our house, bringing casseroles, they said, oh, well, you did. He called Billy, and he called Brian, and he called them all on Tuesday, and he died on Friday. So, I think that's why I think a discussion of suicide is really important, because if the public knows these things, excuse me. So yeah, communication's important. I also think that you should follow your gut. When it deals, suicide isn't a logical thing, and mental illness is not a logical thing. And if you are talking with your friends or your family or your coworkers, and they're giving you advice, and a lot of that advice might be tough love advice, and but they don't realize really what it's like dealing with someone with a mental illness or how they feel. So I think you just need to follow your gut when someone says, well, yeah, if he wasn't answering the phone, I wouldn't call him back either. If he said he didn't want me over there, I wouldn't go. You've tried everything. And, really, sometimes people don't say what they mean, or you just need to keep going. You shouldn't give up. So follow your gut on that. In the same way, as far as whether they're seeing a psychiatrist, something doesn't feel right, if they go in the hospital and things don't seem, you walk in and the people at the desk are eating their hamburgers and they're not really caring about who's coming in, and you go up and you're just having resistance, you just have a bad feeling. I've thought many times, like, why didn't I yank Cody, out of that situation? So yeah, follow your gut, don't think about logic. Slow down is the third one. I think when people get upset, they work really fast and don't really think. Just try to hurry up and make it better. And when Cody was going to college at Fayette, I remember he was going through episodes of being up through the night, walking around, couldn't sleep, what he would call freaking out. He would think, the FBI had followed him home, different things. And so one night he went to bed, and it was just myself, and my husband was out of town. And I got up the next morning, and he drank a bottle of wine. We'd kept all the liquor out of the house, but he'd found a whole bottle of wine, and he was still drunk. And by golly, I was going to get him to college. I called him, and I I didn't go to school that day, but boy, I was going to get him up there, and we were going to drive to Fayette, and I was going to get him to that school. We were going to make it happen because we weren't going to stop for anything. I bought him sunglasses. His eyes were bloodshot. I think he was still half drunk. But you just need to slow down and step back and think about the big picture of things. And I was raised in a family where we did things the right way. You went to college right after high school, and you got your degree. And if you didn't do good in class, you changed your degree, and you didn't stop. So when he had a psychotic break, and we went to Valley Hope, and they said he needs to be in here. Well, gosh, no. He wouldn't be able to go. He would have to be out of school because they don't have an outpatient program, and we can't do that. That's not the way it happens. And I think that's a lot of pride, and I think the key had pride too, though. He would feel a loser. So anyway, that's it. To slow down, swallow your pride. And boy, that's a lot of stuff, But I think, if the public would hear just a little bit here and a little bit there, and we even heard a story from each other, that's going to build. You're going to have some prior knowledge, things to share with other people. And I think just feeling like you can share is a big deal. Stigma. And so just one last thought on that. I have older friends like in their 80s and 90s that I just love. And they said, you know what, Marla? They said, there used to be a stigma with cancer. It used to be no one would talk about cancer. And look now, people are real comfortable with it. You don't mind saying, oh, how was that? Did you have to go through radiation? But wouldn't that be wonderful if we could still have that same kind of discussion about suicide? Yeah.
Well, on our panel, we haven't heard from Lindsey Parton yet, so Lindsey. Lindsey, can you tell us what the school district is doing to identify children at risk for suicide, and also what steps the school district takes once a child has been determined to be at risk?
Okay. I collaborated with our school counselors on this question. Richard was kind enough to give them to us early. It varies across the ages, and so that's why I wanted to make sure that I covered everything. So, of course, if there is a student who is actively speaking of suicide, the counselor is the first person that the teacher probably will contact, and they will kind of assess the situation, call the parents, call the family, encourage them to find assistance for the student. Now, if they're not actively speaking about it, but there's just some risk, some self-harm behaviors and things like that, then parents and guardians are still contacted. We have really pushed this school year to get our staff to build relationships with their students. I think that they've always built relationships, but even like the first 3 days of school, our teachers weren't teaching, they were building relationships, and I think that that was very important. I was very excited to hear that our staff was asked to do that, because by building those relationships, we know our families and our students better and can identify their behaviors, I guess, their expected behaviors. So that is, did I answer the questions?
Mm-hmm. What is the process the school district has to support students if a classmate or parent dies, whether by suicide, illness, or sudden death?
Mm-hmm. So once again, the counselors, the social workers would be called in, and we would assist in listening, providing support. There's different support techniques that go, once again, depending on age. There might be memory books made, or there might be support groups or things of that nature. If we had a need to call in other school districts, counselors or social workers, we would likely do that. If there was a pretty large crisis, we would call in other professionals to assist us if we needed more manpower to handle a situation.
Okay. Very good. Thank you.
Mm-hmm.
These questions for Dr. Farhmeier. One of the challenges that we have is availability of psychiatric care. We talked a little bit before the meeting tonight that you have a map of psychiatrists that are available in our state. Can you kind of talk a little bit about that?
Sure. Just a second. The map that Richard's talking about is the Missouri Health Hospital Association just released this map of These are psychiatrists available in the state of Missouri. As you can see in Saline County here, this is per 1,000 county population over the age of 18. This does not even go into child and adolescent psychiatry, which is even less. The state of Missouri has done some things to kind of help bridge that gap. So, there is telepsychiatry available in the area in the different agencies and locations. This is not, shortage isn't just Missouri, it's across the nation. So the psychiatry is not the easiest to get into right now, so we do rely a lot on the other mental health providers besides the psychiatrists, such as the social workers and the licensed psychologists, counselors, and so we work as a team. And our nurses, it's all a teamwork with psychiatry and wraparound services. So for instance, I'm actually the only psychiatrist in Saline County that you can see face to face. The next ones that you can see in Pettis County, there's a couple psychiatrists there, and then you're looking at Macon, Missouri is the next closest, and then you're going to Kansas City. So that just kind of gives you an idea of the workload that we are seeing as psychiatrists, especially just face-to-face. It's not an easy task, and honestly, telepsychiatry, it is available, and there's a lot to be said for it, and I personally don't do it myself just because I love seeing my patients face-to-face because it's that personal touch. However, it is something that's very necessary when you only have this many psychiatrists in the state. And so oftentimes it's those wraparound services and support that we have to rely upon.
Okay. While you're up there, I've got another question from the audience. Do other states have different laws about hospitalizing suicidal patients? Is 3 days a pretty standard law?
It varies from state to state. There's anywhere from 48 hours to 96 hours is actually a pretty long time for the hospitalization for that. I trained in Ohio and it was 72 hours there. The Missouri state laws are written, there's only 3 states in the union that still have imminent harm to self or others still in the state constitution, in the state laws. So that is something that's been taken out of a lot of the states' mental health laws because imminent is sometimes hard to predict. And that's why some of the other states have taken those out. So yes, it varies state to state. And even from our counties, there's differences in opinions based on some of the interpretations of the law.
Thank you. Roger Gibson. This is a question from the audience. As an officer who is called first, how do you decompress from such calls? How are detainees maybe assessed for risk of suicide or put on suicide watch?
Wow. Who wrote that question? That's a good question, actually, for real. A lot of the officers, depending on the severity of the situation, youth is always hard for us, elderly is hard for us. Just about anybody is really hard for us. So even when they attempt and do what they want to do to try to carry out their plan, is hard for us. So we try to empathize, get with them. After it's all said and done, we look to chaplains and we take them for ride-alongs and we'll layer out, what's on our heart. We have the hospital staff, which is good as well. We have some outs that we go and talk. Usually it's one another. Usually the youngers will come to the olders, just say, hey, have you ever dealt with this? Yes. What'd you do? Here's how I dealt with it. And just pass on a little wisdom, hopefully, to help them get through that. Because, we have families, we have children, we deal with things too, just like you do. So sometimes if it's really bad, we're a smaller circle, so it's kind of hard. It's hard to explain that, but we get through it the best we can. And that's not just limited to this topic. That's to other things that we see, bad car accidents and everything else that goes on around us. So, yeah, there's a lot. So we may have to see the doc more often, maybe. I don't know. But it's nice to know that we have that available to us. There's a lot of law enforcement agencies that do not. And they'll go through some big crisis and they just leave their officer alone and they just have to deal with it. So, which is tragic. And what was the rest of your question?
The second part was how are detainees assessed for risk of suicide, and how are they placed on suicide watch, or are they placed on suicide watch?
If they make, and of course, they don't want to go to jail sometimes. So during our first meeting with them, it may be all yelling and screaming and we're bad guys and we shouldn't be getting involved in their stuff and it goes on and on and on. Then the handcuffs come on once we do our investigation, and then it's like, oh, I'm going to kill myself, or I'm going to do this, and then all of a sudden these things come out. We don't just put a blind eye to that and say, no, you're going to go to jail anyway, you're done. We take that seriously. Like I said, preservation of life to us is number one. For them to even make that utterance, we take that serious. So off we go to see the hospital staff, and we ask them to evaluate them. I mean, that's beyond us. They're qualified, they're trained, they're available, so that's what we do. They make that assessment, and then they tell us, yes, they're fit for confinement, or no, they're not. And at that point, if they're fit for confinement, they go with us. Once they're with us, we do monitor that. We do have suicide watch in place, so like every 15 minutes, there's somebody going in to check on that prisoner, seeing where they're at, talking with them. How you feeling? How you doing? I'm doing okay, thanks. Let them come out, make a phone call, call a loved one, family member, somebody, and then that seems to ease it as well. So we don't just let them go without any watch. So that's what we do.
Okay, thank you.
Answer that.
At this time, I am out of questions. Do we have any other questions to hand in? Panelists, is there any topic that we didn't cover tonight that you'd like to speak to, given a moment?
One of the things that we talk about is the people who complete suicide, but we don't talk about those who attempt suicide and what happens as a sequela of that for the families. Thinking about people who attempt it and maim themselves terribly. I think about the one young man that shot himself here with a gun and wound up blowing off his face, but he didn't die. And now he's left living with a more hopeless situation and the devastation to that family. I also was sitting there thinking about a young woman that I'd worked with that was 21, I think, that decided she was going to do an overdose. And she overdosed on Tylenol. And if you know anything about Tylenol, which Mary does, it's not an instant death, but her family had to then sit and watch her die over a period of 2 weeks as her liver shut down. And, and so that can be as devastating, those attempts. My son, and Marla and I were talking about the mental health issues, and our son had mental health issues and drug and alcohol issues. And Ben, the reason that his mental health issues came to light was because he tried to drink himself to death and cut his wrist, and I wound up carrying him into the ER in my arms because of alcohol poisoning, where he wasn't breathing, and the devastation that's there, even with attempts, is horrible for families. Now, it can be good. I have to say, for at least for Ben, our son, it was a good outcome. because he got the treatment that he needed ultimately. And, and he's doing well, and he's 34, and he stays on his meds. But there are lots of people that's not the case, that either they don't get diagnosed, or you think it's other stuff, whether it be alcohol and drug abuse, or, you don't always know. And, one of the things that I thought about when Mary Farhmeier was talking was, it's knife and fork therapy. It's not just enough for somebody to be on medications, but they also have to be in treatment. In the same way that you need both a knife and a fork to cut a steak, you need both medication and therapy. And those two things go hand in hand for anybody that's thinking about it, or that is struggling in ways that you may be able to identify. Just somebody who's not at ease. And we talk about disease, it is dis-ease. Dis-ease, discomfort with something that's going on, whether it's sexual issues, whether it's drugs and alcohol, whether it's psychotic break, psychosis, whatever. There's an element of dis-ease that is present. And I think if we can be open to addressing those things without judgment, without fear of repercussions from the law, or but just be open to talking about those things as a people. Somebody was talking about cancer. Was it you, Lindsey, or Marla did? Yeah, about cancer, and the fact that cancer is something that we now talk about. And and I can remember when I was very young in the 50s, I can remember somebody having breast cancer, and I can remember it being whispered, that nobody talked about it. And think about the fact that we talk about it now. And we even celebrate when somebody's past their 5-year survival. And yet, with all of these other things, we don't ever talk about them. So,
Thank you.
I just have it got me thinking about, when kids, when they're little, this is also, and I have heard both of these counselors here that are here tonight, the way they talk to those kids, oh my gosh. If my kids, I think, if they would have changed their lives if they would have heard the things they say. And I try to remember them. I'm like, and I'll talk to my daughter or my husband on the phone and say, oh my gosh, you should have heard this cool thing she said. Like, you get on the bus and they're bothering you and you just do this. I mean, it's amazing. So I'm just saying that if kids could start this, I was listening to a podcast the other day when I was, in the kitchen, I'm peeling apples or something. I'll put a podcast on my phone, try to get smart about something. And so I was listening, and it was talking about emotions. And, boys are not supposed to be emotional, and they're not supposed to show their emotions, and they don't share their emotions, little boys even. And I thought back, in the years, how things keep coming up after the fact. And when Cody was like 4 or 5, he would cry. He would sing, Clementine, oh my darling, you're lost and gone forever. He would sing that, and he would actually cry, imagining that his mama was gone. And so anyway, I think that if, the way that we, as a society, can start helping. This podcast, I got off track. They were saying how, we teach kids to get up and brush their teeth in the morning and take care of their, the health in their mouth, and to, let mom know if, had this and that. But if we would take enough time with their feelings, their emotional health, and they also know, well, how am I feeling today? Is it okay? All right. Check these things out just as they do when they brush their teeth. Things would change, I think.
Thank you. I have a question for Dr. Mary Farhmeier. Now you wish you sat closer, don't you? How is the approach different, or is it, in dealing with the elderly in suicide?
Wow. There's a lot that goes on with the elderly and suicide. They're actually the highest risk population. Especially men over the age of 70 are more likely to commit suicide than any other age group. They also tend to use firearms. So with the elderly, it's very important to get the family, I mean, it's important to get the family involved in general, but level of functioning, diagnosis, medical causes, are all taken into thought and consideration whenever this comes about. It's just a very difficult thing to do because the elderly population tend to be more reserved and quiet about those type of things. Especially, I mean, compared to the younger generation now that airs out all their information on Facebook and everywhere else. As one of the psychiatrists that I know said the id has, this ego and the superego have left the room, but the id has taken over. But that's not how our elderly population were raised, and so it really is getting the collateral information. Sleep has a lot to do with prediction of mood disorders. If you're not sleeping, it's a bad sign. And so if you know that someone's having a sleep problem, especially if they're elderly or they're very worried and concerned, then they need to be talking to one of their physicians. And actually, 2/3 of the people who commit suicide have seen their primary care doctor within 2 weeks, not their psychiatrist. And most of them come in with some sort of complaint, whether it be just abdominal pain or headache, or they're not sleeping, they're not eating. And these are very, very much real, that the primary care doctors are on the front lines. And just to kind of give people an idea, you know, as doctors are trained, we do have psychiatry in medical school for 1 month. Yeah, that's all they get usually is 1 month of psychiatry in medical school. In residency program, most residency programs do not require them to do a psychiatric month. In 2006, the American Academy of Family Practice have started to require that be part of the residency training. So when you do this, I mean, I'm always available to the ER docs. They all know that, I hope they know by now that they can call me at any time. They have been trying to call me more often. But they don't have that psychiatric training that a lot of them take. You know, psychiatric training is 4 years for just general adult. It's another 2 more years for child and adolescent. So this is not something that, you know, all of them are comfortable talking about. So even primary care doctors, you guys were talking about don't get in a hurry and don't skip over things. Well, they get in a hurry because that's how the medical world's set up nowadays, is you know how much time you get with your doc nowadays compared back, you know, in the 1980s where you could sit and have a conversation with them. And so it really is, you know, the elderly population is difficult to kind of detect, and they're very much reserved and quiet about it. And so it's really hard. And so we do take more vigilance when it comes to the elderly population.
Thank you. All right, I do not have any more questions from the audience, but I do want to, at this time, I understand that there's several individuals in the audience from the Department of Mental Health. If you're here from the Department of Mental Health, would you stand so we can recognize you? Maybe not.
I was thinking Anna White. Are you? Well, I'm with Earl.
With Earl.
So I'm kind of with the Department of Mental Health.
Okay.
Kind of stand up.
Okay. I'm actually part of a new program in Missouri. It's only about 2 years old. I'm a community mental health liaison. There are 31 of us across the state. I only take referrals from law enforcement, and I do trainings for law enforcement.
Could you go to the microphone, please?
Okay. I was just saying that I'm part of a program with the Missouri Coalition of Mental Health community mental health liaisons. We're 31 of us across the state. I'm over 10 counties in central Missouri, which is a little bit too large, but I'm in Saline County often and love it. I only take referrals from law enforcement, courts, and I do training for law enforcement officers on mental health and how to handle mental health crises and one thing or the other. And I just got to say, this is the best job I've ever had. And I'm older than dirt, and I've had a lot of jobs. So I'm really amazed that Missouri has this program. And thank you to Judge Harvey, because I think he believes in our program and calls me. It does vary from county to county, and so hurrah for Salem County, and thank you for putting this on tonight.
Thank you. And I did want to recognize Judge Hugh Harvey as well. Thank you for coming. Yes.
One thing I wanted to recognize, the state of Missouri does have crisis centers for each area. One of the crisis number in our area that they have someone on call for 24 hours a day is actually rural. So they are our crisis through the Department of Mental Health in this area. So if I remember correctly, is Hannah here?
Yeah.
Yeah, there you are. Do you guys have iPads that you can utilize with the police officers? Is that correct? Or do you guys use that anymore? They're being updated. But you had iPads to be able to be available face-to-face on call, to be able to help with the police officers to help out. So those services have been available. It's not very well known, I don't think, around here, but it's something that is available that they help work with the police officers with.
Very good. Thank you. Jackie, did you have something else?
I did. Farhmeier is here from Burl, who's the clinic director, social worker. We have Jeannie Harms here. I don't know if Jeannie was the same thing about the behavioral services at Katy Trail. And maybe I know Bobby Hendricks, I think, is going to get NAMI training. I just don't know if any of those people or anyone else here. Melody Smith from Missouri Valley College, who is working with the counseling program. That possibly anyone want to say anything about what you're doing? And don't have to.
I'll speak up for Bobby because she did do the National Alliance for Mentally Ill training to be able to do a family-to-family group for family members who have other family members with mental illness. There's a group through the National Alliance for Mentally Ill for that. She's actually looking for someone who's interested in co-facilitating and maybe willing to go to training for that, to start up a group in this area, which is very much needed. I actually was trained by a past president of National Alliance for Mentally Ill in my training program. Actually, I call my training program Diamond in the Rough because of some of the opportunities I had. It is a great organization to get involved in. Not only do they do grassroots for mental health advocacy, but they have peer-to-peer support groups too, so that people with mental illness can get together with other people with mental illness and talk about their struggles along with families. And it's a great way to learn how to navigate the systems and where to go for support and help each other in addressing mental health. Because like I said, where I trained, I call it Diamond and Rough. I trained in Summit County, Ohio, which actually got an A- rating from National Alliance for Mentally Ill for access to care. So I'm a pretty big advocate for opening up lines of information and communication all over to kind of help us bridge those gaps, because there's no reason to have those gaps if we all are talking to each other.
Okay, thank you. Good. Jackie introduced a couple individuals. Do you want to contribute or?
is inside your packets. We list all the phone numbers, like for Burl, Fitzgibbon Mental Health, Lake Circle Outpatient. I don't know, Keith wanted to say anything about the outpatient therapy. But I'm saying that your numbers are in here, and the support groups, if you haven't noticed that.
Okay, there are a number of brochures on the table back in the back that are free for you to take back to your offices or wherever you would like to distribute those. We encourage you to do that so that we don't have to pack them up, because it doesn't do any good sitting in an office desk in my office. It would be much better if they were distributed, so I encourage you. I want to thank our panelists for your willingness to share your experiences and your knowledge with us. We've learned some valuable lessons about what to look for and what procedures are followed and what resources are available in our community. We can all see that more needs to be done, and this meeting is just the beginning of addressing this issue that shatters lives in our county. We encourage you to not put blinders on when you communicate with loved ones. That waitress, that store clerk, that coworker, that police officer, each of us has a story. When we wear blinders, we run the risk of overlooking that cry for help that may be going out and returning unanswered. As we leave, I want to encourage you to remember to love one another. Thank you. You all have a great night.
Before you all leave, I have been asked, I promised I wasn't going to say much, but I have been asked a couple things. Number one, we want to say thank you to the panel for taking your time and giving some of your expertise and sharing some of the situation you've gone through. Let's give them a big hand. Also, the folks over here said they want their food gone. So when you eat it or carry it out of here, please take care of that.
Or communicate while you eat.
Or communicate, yeah. You don't have to leave, like go out the door all in one big horde, okay? The other person I want to thank tonight for organizing this and being the drum major, all that kind of thing, is Richard DeFord. Richard's done a big thing. Now let's all enjoy getting to know each other.